Right, let's wait for people to join. Okay, what time is it? 2 minutes past. I think we should just start since we don't want to go over time.
Sure.
Cool. Right. Hello, everybody. Welcome to our webinar, Day in the Life of a Doctor. My name is Sarah. I'm one of the tutors for intermedicine. If you've been on our webinars before, you will know me. I'm joined by Muna, who's also been on every single webinar. And just as a small introduction to intermedicine, if this is your first time on this webinar, intermedicine is a platform where we help prospective medical students get into medical school. We remember how hard, how daunting the experience was for us, and it can be especially hard for people who don't have the resources or the people to help them. So what we try to do is we try to provide almost like a level playing field for everyone to master their own application process. And today we are doing our very, very, very exciting webinar. A lot of people have actually asked us to do this one, following our Day in the Life of a Medical Student. This is our Day in the Life of a Doctor. And I am humbled to present our amazing guest, Dr. Raji, who was actually my mentor and helped me get into medicine. And here we are. I go to Imperial and she's a doctor. So let's just introduce Dr. Raji.
Okay, so hi everyone. I am pleased to be here and to talk to you about why I chose medicine, what my life as a doctor is all about. So I started my path in 2010 or so, and started med school at Southampton. Done my med school, graduated then in 2016, did F1, F2, took a time off a bit, and now I'm doing another year of F3 before going into specialty training. So yeah, that's me. So why I chose first medicine was all about my character, who I am. I loved interacting with people, quite enjoyed science, all the sciencey subjects. And then I was like, okay, I should do medicine. A bit different than other people who like they were like young on knew what they wanted to do. I always wanted to do something else, wanted to be a pilot, wanted to be a chemist. But then before starting A-level, I decided, okay, I could do medicine. Let's try that. And somehow I got in. And from there on, everything kept rolling for me.
That's quite interesting. I think that's something that we talk about a lot, Muna and myself, in every single webinar is when you want to do medicine, you have to see it in yourself. You can't let other people influence that decision. And honestly, I can actually say Dr. Raji has the perfect personality for a doctor.
Thanks so much.
He molded my personality for medicine.
No, thanks so much.
Yeah. So you talked about what motivated you to study medicine a little bit, but how did you find the application process yourself?
So I believe I would do medicine again than applying the application process. It's very challenging, and it is hard work, but it is manageable, and a lot of people have done it successfully. One thing is you need to start with your personal statement early, because this is what they look at. This is what they've been looking at for years now. And they have every university has kind of a setting how they want their personal statement to be. So you need to think first, what type of university do I want to? Is it something like more research based? Do I want to go to Cambridge, to Oxford? Do I want a bit of a mixture, like some London universities like Imperial, where you get both? Do I want other like good good education, research, and also looking at your personality, hobbies. Is this more outside London, outside all these Cambridge areas? So when I looked at the universities I wanted to get out of London. I was London based from the beginning, so I definitely applied outside London. And what most of the personal statement look at is you have your introduction, who you are, but they are looking at like at least 6 different types of like care. If it is like hospital, dentistry, elderly, care homes, or whatever else you could do, this is what you can put in. Other things is what makes you stand out. Is it is it being multilingual? So I speak 4 languages, so I could put that in. It's made me stand out more than others. Or have you won a prize for something, for poetry? Are you very good in sports? So you could say I was a captain in something. So anything what you think makes you stand out, because they read so many personal statements where they just can't distinguish. And then things like they expect you to have like, oh, I've done GP placement, GP work experience, or other care homes or so. This always stands out. However, don't think it has to be like that. You can work in, some people have gone into the personal statement with working in McDonald's, but the way they presented it, how, yeah, I had this challenging customer coming up to me and I had to like communicate with them well. So buzzwords. So see, as a doctor, buzzwords like communication skills, time management, team working, and other things, all these organization skills. There are a lot of buzzwords you can like write out and then see how you can link them to your work experience you've done. So it's all about, I've done GP placement, this is what I learned, this is an example kind of, but make it in a nicer flow. Other thing is make a lot of people read your personal statement, because every person is going to give you new ideas, the way, either if it is the way how you should write it shorter, because there are only a limited number of words you can use, or the way you should present it more. So everyone will help you a bit. Then, so personal statement ahead, then there are all these UK CAT, if you want to go into certain medical schools, then BMAT. I think UK CAT has changed for the time I did it. There's more like a situation tests and a lot of like time management wise, you need to answer quickly. This all needs practice. There are so many website outside, also Into Medicine has been like giving you tips and advice how to do it. There are other question banks you can use just to make it practice as well. And as a doctor, generally, you need to see patterns very quickly. Anything is like when you go to the ward and see a condition, this, oh, you know, this is the condition I'm looking for. This is the investigations I do. There's always kind of pattern work as well. So that's why I think they've put this also in your UK CAT. So there are a lot of things that you need to learn and see how you can manage. And just be sure this is what you want to do. Like medicine is, there's nothing not challenging on being a doctor, but it's the most beautiful career you can choose if you really love it, if you're passionate about it. If you choose it for because all my family is doctors, this is the thing I needed to do because I don't know anything better, fine. If you really like it and saw the challenges of your family and then thought, okay, this is something I can do. Or is it because of recognition, especially now in the pandemic, everyone, NHS and doctors are great. Is it something you look for that? Okay, is this the only reason? Then it might be a bit challenging. But if it's for later, if there are other reasons as well, you're looking for that, that's fine. things like what people think about us being paid and have a good like payments, forget about that. But there are other more amazing jobs you can do for if you're looking for financial security. However, you know, as a doctor, you always need it, so you always have a job, whatever career you choose. So yeah, this is the application process. Then a lot of what can I talk about interviews maybe. As a medical student, depending on which university you go, there are different type of interview stations. So if you go to if you do on other places, you can have like they have a panelist. Sometimes there are 3 consultants from different specialty, 1 admin kind of person sitting there as well, asking you question mostly about your personal statement, about who you are, why you want to do medicine, why medicine, not something else. They always ask this question, why medicine, why not dentistry, why medicine, why not nursing? So know these things about why. Other universities which are more challenging, maybe Cambridge, Oxford, they ask more a bit about medicine, a bit like about biology, a bit more like about stations, what will be into medicine. But I'm sure into medicine will do a station about maybe interviews later on, and then this will be discussed properly. So yeah, so this is a quick kind of
very
crush.
detailed, actually.
Yeah.
Very detailed, yeah.
Really, really, really good to hear, to be honest with you.
Yeah.
The application process changed.
A lot of really good advice there, actually. That's really good. I agree with everything you said, basically. Could you tell us some stuff about your actual experience of medical school itself, like your general experience throughout your 5 or 6 years or however many you had?
Okay, so medical school, well done for getting into medical school. Is the challenge you had to face. Maybe you've been working hard the whole time, maybe just short term like me at the end decided to become a medic. Whatever you did, you deserve to be in medical school. As you work so hard for it, as you're passionate about it, you deserve to be there. So always think positive. There will be many challenges. Medical school is like a up and down experience. You will come into a big cohort, so they're going to be maybe 200 people, or in other universities even more than that. And you need to find first your niche, so that you're gonna know you know yourself. Are you a sporty person? Then suddenly you will sit with the sporty people. Are you more about outgoing? You will be with the outgoing people. So this is quite funny. I think every university has that, always these groups. But what's beautiful in med school, you always interact with everyone, because you're always gonna be put with other people in like smaller groups to discuss maybe papers, or smaller groups to go to GP practices together. So there are different, like, you will interact with everyone. Everyone is lovely. Everyone has their own story to tell anyway. So you will always have good good rapport with everyone. It is challenging because it's something new. You are from A level, small groups, like, you know, your teacher, you have a good bond. Then you are with a lot of people. You might not know your professor so well. There are gonna be many lectures, and they're gonna like teach you so much in a short period of time. And you think, oh my God, I have to know everything. How am I going to know everything? How am I going to pass the year? This is too much to know for a human being. And it is. So you need to be very smart about, first, know what type of study person you are. Are you a visual person? Are you more audio? Are you more, do you need to like act it out? Do you need to speak it out? Do you need to draw it, paint it, mind map it, note it? There are so many personalities. For me, I'm a visual person. So sitting there hearing all the lecturers talking about all these biochemistry, physiology, pathology, everything was like a bit too much for me. All these handouts, PowerPoints. What I did then, went into YouTube, got it more as a visual picture. There are a lot of people who draw it out for you as well, the physiology, the biochem, and this is how I learned it. Always know, you never in your life, before your exam, you tell yourself, I know everything what I learned, what I'm supposed to learn. What you need to be smart about is know what is important, what you think is what you can know, because at the end of the day your brain can take only a small amount. So always know from everywhere everything, kind of, and then the others need to be taught to you slowly. So start early, study early, know yourself. Maybe you like studying in the group, maybe this is waste for you, you need to study on your own, maybe you study at night, at day. And I think during A-level, you kind of slowly know how to study. And then in medicine, you will like carry on. In medicine, during medical school, how many years you go, some universities start early with patient contacts. Like my university, I went to GPs early on, witnessed a birth with the midwives early on in my second year. So I had a very quick face-to-face with patients, which was very interesting, which I loved. And other universities know a bit later, maybe third year, maybe fourth year, depending on what university you go. So this is also a time where you choose what university you want to go to. So also you need to balance your life from early on. You, in the beginning, when you come, you are overwhelmed. You think like, I have no life anymore, that's it. I'm just studying 24/7. There's too much to do. I need to go to lectures. I'm never gonna go to my friends' weddings, which to be honest, I didn't manage to go to everyone's wedding, but that's fine. You pick and choose. So you need to find hobbies. You need to let medicine go a bit as well. So say you have lectures till 5 o'clock. Afterwards, maybe relax a bit, go to the gym, play tennis, go meet friends, talk to your family. Always have a bit of a balance, because it is challenging. It's a long years. We are a course which is long, and a long course, and where a lot of information are given to us. There will be a lot of stresses during medical school. I'm trying to be here honest, because I don't want you to get into medicine and be shocked. There are going to be stresses. So you need to early on learn about yourself, see what creates anxiety for me, or what are stress factors. Is it if I am is it the everything I am learning? Is it for me like comparing myself? The problem with us medics generally, or people who are smart, because we are above the average. That's why we're getting into medical school. It's not like we've worked hard, we know ourselves. So sometimes we compare ourselves with others, which never do, because everyone has their own pace, everyone has their own talents. Some people are very good in exams, but then in OSCEs, they are not very like practical kind. They are not the best. Some people are good in like presentations. Some people, so you know yourself. So never like compare yourself to others, because as I said, you deserve to be there, and you worked hard for that. Other things is join societies. See what you love. Do you love dancing? Go to a dancing society. Do you love painting? Go to their sports. Are you interested in a specialty already? Say you're interested in surgery, go into the surgical thing societies. There are GPs, pediatrics, all these medical societies. Go join, find people who are like-minded like you, talk about it, talk about the challenges of medical school. And so this is how you kind of survive medical school, because
that's
all
actually
of
one
things.
thing that when I picked up when you were talking about how to balance medicine with the rest of your life, is that to almost incorporate like your friendship group from uni and everything with your studies. So you can study, but then after your lectures, go to a society event, join cultural societies. It doesn't even have to be medicine specific. You can join cultural societies. You can, a lot of your friends in uni are going to be people who aren't medics, whether they're engineers, mathematicians at Imperial.
And this is fun.
Yeah. And so that's what kind of allows you to balance your life.
Yeah, indeed.
If can I move on, or Kotha, do you want to?
No, just move on. You know me, I'll keep talking about everything.
By the way, guys, thank you for your your questions in the Q&A function. We will try and cover all of them by the end. If not, we'll cover them at the Q&A segment in the end. But we're just going to start talking about your life as an actual doctor. So when you started to practice medicine as a qualified healthcare professional, what was your first day like? What was your, how were you feeling? How's your first shift? That's something that I've always been interested in. I'm like, I study medicine now, but when I'm a doctor, what is that going to be?
I'm so curious about what's going to happen in a few years. I'm just like all nervous already.
So the good thing is you early on know you apply for your F1 posts, and then you get ranked, and then whichever rank you get from your exams points into whatever you did before, you will then do an SJT as well. You get a number, and then at the end you are ranked with everyone in the UK, and then hopefully you get your first choice. So for me, I got my first choice because I wanted to do surgery, especially heart surgery. So I managed to get into the Cambridgeshire area and into it was Huntington and Papworth, which was Royal Papworth, where the heart surgery is very famous there. So in my first day, oh dear, so everyone fears the first Wednesday of the August. Oh no, these new fresh doctors are coming. It's going to be a disaster. They are just from medical school. The first day, it's induction. It's going to be long, drainful. You learn about fire hazards, about death certificates. You learn about like a lot of things, like you do a bit of all these compulsory things for the hospital. So the first day is, as a doctor, it's not really the first Wednesday. It's just induction. Maybe Thursday is induction as well, and then maybe Friday you get onto the ward. So whichever specialty you start in, mine was a medical specialty, so it was like a stroke unit slash medical unit. So what we did the first day, no consultant, no registrar, two F1s on the ward. So you come to the ward fresh, excited to be a doctor, and then you're there and you're like, oh, my consultant is not here. He's in clinic. Oh, my registrar is in clinic too. What should I do? Then you have the nurses. Always the first thing you come is introduce yourself to everyone. Every time, whoever it is, if it's the nurses, the HCAs, the physiotherapists, the occupational therapists, the cleaner, the porter, everyone, just say, oh, hello, it's me, I'm Dr. Raji, I'm the new FY1 here. Yeah, so I just wanted to know, how do you normally start your day on a Friday or so? And then they will tell you, oh, normally the doctor goes around, does a quick ward round, and then we meet for a quick catch up at I don't know, 12 o'clock, and then we discuss all the patients and all the estimated discharge date. That's very important in the hospital, and then we carry on. So you know yourself. So what I did with my F1 colleague, so we divided the ward, did a quick ward round. A ward round. I'm sure you, as a medical student, you will be on so many ward rounds. So, and you will meet so many different consultants, the way they do it differently. So whichever specialty you are, you know the ward rounds. If it's like surgery, it's quick. Oh, the patient is alive, ops are stable. Okay, this is the plan. He can be discharged. Goodbye. Then you have the elderly care. It's like, okay, so how are you today? Okay, so any tummy pain? Oh, did you open your bowels? Are you eating and drinking well? It's a bit longer. And then you have like your kids ward rounds, where like you're just talking, making funny faces with the child, playing with the child, and then talking to the parents, very serious about the condition. So every ward you are, it's a different type of expectation how to do a ward round. So I knew that in medicine I have to be a bit more thorough. So always checking the observations, checking the urinary output, checking the bowel charts. There are so many charts you will notice when you get into medicine, and then on the wards. So checking and then talking to the patient. Are they okay? Is there anything new, any concerning thing that the patient will tell me, or is it me? Then if you have no idea how to do a ward round, it's always to do ABCD. In medical school, as a doctor, in everywhere you are, they will teach you ABCDs: airway, breathing, circulation, disability, and everything else. So you will then say, okay, my ward round is going to be that. You are a safe doctor then. As a doctor, you need to be safe. And this is what's the most important thing. You need to know, be safe, know, recognize acute unwell patient. The first thing they will always teach you is observe. See what is your patient unwell or not unwell? Are they stable or not stable? And you see that. You don't need the observations, you don't need anything. You just look at your patients and you know they are well. The way they breathe, the way they look, the way they communicate to you, the way they sit, lie, everything, you know that. Because we're human beings, we know when someone is unwell. So yeah, so done my ward round quickly, met with the therapist and everything, and made plans already. I felt like a doctor. But then on one day, but fast forward on a couple of occasions, then it is elderly patients, so most of them are stable, kind of doing physio or TO, they can't go home. One day, suddenly the nurse comes up to me and says, this patient is having a seizure. As a F1, yes, we've seen a lot of seizures, but this is a patient who doesn't have epilepsy. So what do you do? Again, my consultant isn't there. Nobody is there to help me. It's just me and the nurses. And nurses, they are very good on their parts. They recognize things. They will always prompt you if they think you are not doing everything correct or you are unsure. They will give you confidence. But as a doctor, it's you who decides, who makes the decision. So whatever acute patients, again, I went there, ABCD. Oh, I didn't feel like his airway was managed properly. He wasn't like it wasn't patent. His tongue was kept going back. I took a Gadel. Told the nurse, can you put a Gadel in, which is like a small, how do you describe it in a non-medical way? Is like is it like a tongue depressor, but in a shape like this, and then you put it in, twist it, and then the tongue goes down, so the airway is open. This is managed. The patient is still shaking. Okay, moving on. So I've secured this. Is his breathing, listening to the chest? Is there anything else I'm managing? Is the patient safe? Am I thinking he's vomiting to obstruct his breathing? Is there any secretions I can like suction out? So you go through your assessment as a doctor and then make a plan and then say things. Then it was too much for me as a one person. What I did is I called the medical registrar on call and told him, this is what's happening. This is what I did. And I think I need help because I don't know what else to do for this patient. Then the medical registrar came. I called as well a peri-arrest or an arrest because I needed more hands. So most of the time is if you don't know, there's always support. You just need to know how to get it. And as a doctor, especially as a F1, when you start on the wards, on your on calls or wherever you start, there are always people to help you, and they know you are new. They know you have no experience. They know you are scared, that you are nervous, and they will know that, and they will prepare themselves for all the questions where we think, oh my God, that's a stupid question. How can I ask the medical registrar this? He will say, okay, no, they will help you. They will give you answers. They will teach you as well. They will be your guidance through all your difficult shifts. So yeah, so it is challenging at first, but there's a lot of support there and you are prepared for it. Don't think you are not prepared for it. All these 5-6 years of medical school prepares you for that day.
That's quite interesting. Just there's a question that's been asked like a couple of minutes ago
Yeah.
about, but I think it's quite relevant right now
Yeah.
to what you were saying about why teamwork is important as a doctor and what does teamwork in the doctor's context actually involve.
Okay.
And you just gave a great example of just that, teamwork. Do you want to expand on that?
Yeah, so as I said, so on a ward or wherever you are, it's not just doctors. As I said, there are nurses, there are occupational therapists, there are physiotherapists, there are cleaners, there are porters. All these people make up a good care for the patient. And this is what's all about at the end of the day. We want great care for our patient. We want to manage his condition to get him safely home. How do you get someone safely home? Is not just, okay, oh yeah, as a doctor, I made a diagnosis. This patient has, exacerbation of asthma. Okay, but am I gonna go initiate all the treatment? No, it's my nursing colleagues who will help me get the nebulizer going, get the oxygen going, get me the help me organize other things, get me the peak flow. So there are a lot of things that they will help me with. Then there are the HCAs, healthcare professionals, who help me with the observations, monitor them. They will recognize if it's off and tell me. There are my friends, the porters, who will take my patients to have his x-ray. There are my physiotherapists who will do chest physio, help the patient the way how he coughs, how he brings his sputum up, how he can then clear the pathway to breathe better. So there is OT who will then assess the patient. Is the patient safe to go home? So this is the beauty in medicine. It's not just one person sorting the patient out. There are so many people who help during an acute stage or chronic stage of an admission. So this is what teamwork is about. If you are a person who thinks like, I'm sorry, I can do everything on my own, you will never manage life, actually, not just medicine, because in everything we do, that we need support with other specialties, other people. And yeah, teamwork is the thing which keeps the NHS going and keeps you going.
Yeah, that's very, very true, actually. And I see it when I'm doing my placements in the hospital and everything. And I didn't think it was, because when the stereotype of how hospitals work is the doctor comes in, he orders everything, and then he leaves. And then we don't really hear about what happens in the back.
Yeah.
But when you're in the hospital, and I think people who have done the work experience and stuff will see that there's so much teamwork happening, and there's the whole idea of something you should put in your personal name, actually, of the multidisciplinary team.
Definitely.
The
MDT, well done.
Which is something everyone has to put in their personal statement. You have to say, I'm a good teamwork, I'm a good team player, and therefore I will be a perfect medic, because
because it's all this is all about medicine. So if you're a team player, if you communicate well with them as well. If I make my plan and just write it down and then go away, what? My patient's not going to get better. It's me going up to the nurse and say, okay, so I saw this patient, this is my plan, can you please initiate the treatment, or initiate the transfer to the patient to another hospital, or whatever you want. You need to communicate, or you ask your OT, PT colleagues, okay, so how much can this patient actually do? Or is this now his baseline? Do we need to think how to get him home? Is home for him safe? Do I need to think about nursing home if it's an elderly patient now, or any other disabilities have been occurring during his admission? So yeah, so F1 is a beautiful new start, and every day you learn something new. Every day you will get more experience and you will get more confidence. And then on-call start. So some people are lucky or unlucky to start with their nights as a F1. Maybe your first shift is a night shift. Maybe your first shift is your on-call shift. But this is what I kept telling you in the beginning. Don't be worried at all. Everyone is there to support you. Sometimes the registrar even starts with you at your first on-calls, and then knows like, okay, if you give me a call, sometimes you don't even know how to interpret an ECG. It's challenging. Sometimes you just go to your registrar and say, I'm sorry, this patient had this. I did the ECG, but I'm not sure. Is this an MI? Is there an ST elevation? Is there a thing? And then they will help you. They will teach you. And this is what's great about teamwork, about this, about knowing your limitations as well. As a doctor, know your limitations. Never be scared to ask for help, because everyone was in your position, so everyone knows what's going to happen.
Yeah, you spoke about doing on-calls and night shifts. What was your first experience of a night shift like?
Okay, so my first night shift, I don't really remember when was my first night shift. I've done so many over the years. It is different. So your routine is different. So in the beginning, we all get our rotas, depending on how many F1s there are, how many SHOs. So the rota pattern changes. So if, say, you only have seven F1s, then you're gonna do more on-calls than if you had 10 F1s on the rotation, like as a medical rotation, surgical rotation. So every hospital is different. So is it a small hospital? Is it a big hospital? Are there more like doctors around? So you're not the only F1 on your own, you're like with another colleague. So so mine, I started in a very small hospital. So as a FY1, I cover back of house. So that means the wards, I cover all the wards on my own. And my registrar and my SHO are in A&E clerking new patients. Okay, so it was a hospital with like 7 wards, 7 medical wards. And even if it was a small hospital, all the wards were in different places. So I had to walk from one place to one place. And in the beginning, I wasn't very smart. So I was like, okay, they call me for a job, I quickly go there because I think like, oh, it's important. I need to see what it is. I need to do it quickly. Then I got so tired. Like the first on-calls during night or generally during the day, they were very, very stressful because I wasn't organized very well. I didn't know. Then later on, my second set of on-calls, I became smarter. I knew, like, made myself like a map on a paper. Okay, I knew that these wards are together. These wards are together. And then so patient nurses would call you, oh, this patient needs IV fluids. And I'm like, oh, okay, I would come in the beginning. Then, no, I became smarter. I was like, why does he need the IV fluids? Is it because of what, is it because he's not drinking enough? Is it because his renal functions are off? Is he not peeing enough? So there are a lot of options. Is his observation, is he unstable? Is there sepsis? Is there a lot of things go into your head? So you need to clarify the importance. A lot of jobs might be just important, but the nurses don't know how to tell you it is important, depending on the level, or other things are not so important and they make it sound as important. So you need to ask the right questions to organize your job list. So say this patient, or they are telling me he has a PR bleed, so he's bleeding down from his bottom. That's more important than someone, oh, I'm sorry, he's not drinking, so we need IV fluids overnight. So you learn to prioritize work by asking the right questions, then knowing as well where to go, like, oh, I know that these wards are together, maybe let me do the jobs together and then these jobs together if there is nothing acute going on. Other things was, I would ask the nurses, you know what, can you make a list of all the jobs you think during the nights which are not urgent? And then I make my round the hospital, which was a very great idea. And then I will go through the list, because there are a lot of jobs like, oh, the doctor has forgotten to rewrite this antibiotics for the night, or the doctor has forgotten, because we have so many stuff to do during the day. So yes, some doctors, not everyone will remember everything to rewrite the drug chart. Oh, there was only one space, you have to do. So there are a lot of like, okay, maybe not as acute important jobs. So you need to prioritize. Then there are a lot of like, oh my God, doctor, there's a patient who has chest pain. Okay, in my head, this is important. I ask my right questions. Are the observations stable? Have you started treatment? Have you given him anything? So, and then I go assess the patient. And every time you go assess an acute patient, and you don't know what to do, or you have an idea what to do, you can always call your medical registrar. So I used to call my medical registrar, tell him, this is Mr. D, he is 78-year-old, he experienced chest pain like this, maybe radiating to the left, to the jaw, whatever it was, unwell, shortness of breath, blah, 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 and I've initiated this treatment, and I will do these investigations, ECG or whatever I did, and then we'll tell him, and then he will tell me, oh yes, okay, well done, yeah, let's do, and I'll come review him after. If you don't know what to do, just tell him, I'm sorry, I assessed this patient, I'm not sure what to do, and then he will still help you. But as a doctor, always get the habit of assessing the patient, making a plan yourself, so you learn. And even if the plan is wrong, say someone has I don't know, has a myocardial infarction, but you think it's reflux or something like that, I don't think anyone would do, but and you tell them, your registrar will say, okay, take a step back, tell me again how the patient presented. Do you really think it's reflux? This is just a example now, but yeah, so always make a plan so you learn as well. And this is how then you become a better doctor, by being brave enough and confident enough to assessing a patient, making a plan, discussing it, and initiating.
I think that's also something just to point out for our prospective medical students, to write in your personal statement or to talk about in your interview, to talk about your organizational skill, because you can see how important that is when you actually do become a doctor. Just to move on, if we can, because we are running out a little bit of time.
Sorry.
No, but just talk about right now, so you talked a little bit about how your ward work kind of worked. So you went ward rounds, you did jobs, but now in comparison to surgery, so you wanted to do surgery specialty, that's why you ranked for surgery. Could you talk us through like a rotation of surgery?
Yeah, sure. So surgery is different. So in my hospital, it was a small hospital, but where the F1 carries the bleep for referrals. So GPs would call me during the night or during the day and tell me, this is a patient who says has a PR bleed, or who has an abscess, or who has an acute abdomen, who's been like having pain, vomiting, or does he have a bowel obstruction? And then I would hear the handover from the GP, and then I would accept it or challenge it. Is it really bowel obstruction? Has he not passed any wind? Has he not really opened his bowels? You know, like, is it tender? Where's the tender? So it's always about asking the right questions to get to the right diagnosis. Then I would accept the patient. He would come. This is doing my own calls, by the way. He would come to the A&E. I would assess him. I would start initiating treatment, investigations, and then let my registrar know if it's an acute patient, or if I'm confident and happy to manage him without assistant, I will manage them. So that's in the on-call settings. In a normal setting, it was you have your registrar, your consultant. You are attached to a team. There are different surgical specialties. Like in medicine, you will cover the cardiology, gastro team, elderly medicine, acute medicine. There as well, we had upper GI, breast surgery, we had colorectal surgery, and we had plastics, but they don't really take trainees. So then whichever team you belong, there is a different rhythm. So if it's like breast surgery, they need, most of the time they need the F1s or SHOs to go into theater to help them, like either hold things or stitch up things, depending on how much your level is in surgery, to assist them with it. So I quite enjoyed surgery, so I kept going into plastic surgery, into breast surgery, to do my stitching skills, do assisting, and learning new skills because I wanted to become a surgeon. Some people are not interested in surgery, which is fine, because so they enjoy being on the ward, doing the ward jobs. So in surgery, the ward jobs are as other specialties as well. So you go in the morning, ward round. It's a bit quicker, which is great in some cases. But then in some cases, it's too quick. So your consultant kind of sees the patient and you're like, where are the notes? Where's the drug chart? I'm not finding anything, and he's already gone. So this is where teamwork comes into play as well, because sometimes you have another F1 colleague or your SHO or your registrar where you can like say, okay, I am the one, go grab the notes quickly, you look for the drug chart, and then one of you guys has the iPad for ops, depending on which hospital you work. Some are next still on paper. And then we do everything together. So then the ward run goes smoothly. The problem is in the beginning we all knew, so we all don't know where things are, so it's all chaotic a bit, but people get the hang out of it very quickly. So after the ward work, you sit down, arrange a job list of the day. Oh, do I need to do discharge summaries? Do I need to request scans? Do I need to initiate treatment, antibiotics? Do I need to book this patient into theater? And this is what a doctor needs to understand. There are jobs which are important and jobs which can wait. So say you finish your ward round, it is lunchtime. So before going to the lunchtime, think to yourself, what is important right now for me to do quickly before me going for a break quickly? And never forget your breaks. Everyone, honestly, we are the worst people in taking breaks. Like I see everyone taking break and we're like, oh, it's 4 o'clock, I'm having my sandwich now, walking. No, don't do that. We will do that, but don't do that. So it is important to initiate treatment. It is important to book your scans quickly. If it's a discharge summary and patient is going now, okay, do it quickly. If he's going in the afternoon, okay, do the drugs quickly so the pharmacist can screen them. In the meantime, you have your break, you come back, and then you write what's happened during this day. And you will learn how to do discharge summaries. In the beginning, it's like a two-page story, and then later on, it's like a couple of sentences. So you will learn what is important for the GP to know and what is just for you to know. Yeah, so surgery, this is the way surgery works, and medicine works. So it is all similar, but then the conditions are different and you need to know what to do. And other hospitals have different pathways, which you need to know. So some hospitals, I had to go to the radiologist to discuss the scan and get it accepted. Some people you needed to phone only. Some would just accept anything, and then only if it's very like some random thing you are requesting, they would then say cancel it, and then you have to go. Some people don't allow F1s to go discussers, they just want registrars to discuss it. So every hospital has their own kind of structure, how things work.
If we can compare medicine to surgery, yeah, what would you say the timetable or the routine or the rota looks like for surgery versus medicine?
Okay, so most of the time, the normal days for medicine is 9 till 5. Mm-hmm. That's the routine. And for surgery, it's 8 till 5 because the ward rounds start earlier. Yeah. So it's 1 hour more. In medicine, as I said, the ward rounds are a bit longer, but you have more doctors. In surgery, there are smaller teams. Depending on which specialties you do, and ward rounds are, however, faster. So if you are more doctors, you manage to take your break times, or depending, you can divide your patients more. If you're less doctors but have less patients, or sometimes you are on call, so all the patients fall into your specialty, so there are more patients, more to do, then you need to ask help from other juniors. So don't be afraid to ask for help. I said it many times now during the talk, because other people will be in the same situation. So sometimes I covered breast surgery and we weren't as busy as the colorectal surgeon. So I would, because of my personality, I would ask them, do you guys need help? But most doctors do that. And then they would say, yes, please, can you help us do these discharge summaries. They will give you some things which you can do as a not part of the team, rather than tell you something that is specific. But yeah, I'll do your discharge summaries, maybe 1, 2, maybe I'll go request the scan for you. And then you help each other because you are a team. In medicine, there are more like like in a smaller like specialties, like cardiology are together, acute medicine are together, so they have already a lot of doctors to help each other.
Yeah.
So that's good with them, and they sometimes have more consultants as well, depending on specialties, and they rotate a lot. So yeah, but it's similar. You see a patient, you assess the patient, you make a treatment, you do your ward round, you do the work. So it's all similar patterns. It's just timing sometimes different and challenges are different.
Yeah. So I think this is the most asked question when it comes to medical students, is when do you actually have to decide on a specialty? When do you decide on medicine versus surgery versus community?
Okay. So I tell you my story. I wanted to be a surgeon. A heart surgeon since day one. I got myself a mentor. I did so much heart surgery, lung surgery, got where I wanted to be, even went to Germany to do a month in heart surgery. So I really wanted to be a surgeon. Then came my F1 and F2. I enjoyed surgery. I still think like a surgeon. But then life happened. I had challenges during life, which I had to face, and also other personal challenges. And then I had to decide, does what I want to do really fit with my life choices, my health, my family? And then so at the last minute, I kind of changed my structure and say, you know what, I'll do GP. Why not? It helps me with my family, with my health. And also I can do surgery. I can do minor surgery. As a GP, you can train to become an endoscopist as well. So I can do endoscopy, do biopsies. So whatever specialty you choose, there is always, you can make it your own kind of thing. You can make it part-time, you can make it more specialized. If you just enjoy this type of condition, you make it very subspecialized. So yes, most of the time, if it is surgery, let's say, for example, as I know much about surgery, most of us start early. So during med school, you kind of know, okay, am I a medical type person? Am I GP? Am I surgeon? These things you look at is your character, your lifestyle, your knowledge, your interest, your passion, your experience. So say I wanted to be a surgeon, so I painted the path into surgery. So I went into surgical conferences, I did courses, I did presentations, I did publications. I did everything which I thought will get me into surgery. If I joined the society, I got myself a mentor because I knew I wanted to do surgery. However, some people decided later on as a F1 that they did a surgical job. They always wanted to become a medic, but then they did a surgical job doing F1 and they say, yes, surgery is something for me. I don't like the long ward rounds in medicine. I wanna be quick. I wanna operate. I'm good with skills with my hands, and I like surgery. So then it becomes a bit harder because you need to do a lot of things in a short period of time. However, it's feasible. A lot of people have managed to do that. Do audits. There are so many audits in the hospital, honestly. If it is like, oh, is this antibiotics correct? Do we give catheters to everyone? Do we wash our hands properly? There are so many questions you can ask and answer, and just find yourself a consultant who is thinking the same way, and then get.
Could you just, for people that don't know what an audit is, could you describe what an audit is?
Okay, so an audit is normally kind of a small kind of research or some question you ask to establish an outcome. So if I say, do we as a hospital use the right antibiotics for pneumonia? Okay, then you set yourself a target to say, in 1 month, I'm going to look at everyone who came to, say, respiratory ward and treat it for pneumonia, which is chest infection, and the antibiotics. Does it match our guidelines? And then you kind of see yes or no, and then you can work on it, and then you can find reasons why is that, and then you present it somewhere. So it's always asking a question and finding it, or comparing it to something which is already a guideline or established that it works. And then at the end, you find a solution to it, and then you present it. And then after finding a solution, you can close the loop kind of in the audit, where then, okay, I made this recommendation. I told everyone, you know what, you guys are not using the antibiotics. This, I made, like, say, I made a teaching session to people telling them, these are the antibiotics we're using, you shouldn't use that. And then after another month, I will re-audit it and then see if it made any changes. So there are audits you can do, there's research you can do, which is a bit like longer and more specific into asking a question. So you need to know whichever specialty you choose, if it's like surgery, if it's medicine, if it's GP, what are they looking in your application? So are they looking into a portfolio? So most of the time in surgery and medicine, there's a portfolio you need to do. So how many audits have you achieved? If you have any publication, any presentation, have you shown interest into the specialty? Have you gone like into like a medical, say a cardiology talk or a general surgery talk, or have you done the courses which are specific to it? Have you done exams? So in surgery, you have your MRCS, in medicine, you have your MRCP, in GP and MSR, MRSA, or something like that, MS, multiple, I forgot that now. But every specialty has their own exams which they need to do as well to get into it. So yes, you can choose your specialty early on, which gives you more time to like discover if it is really something for you, and working towards how to get in. Or you can do it as a F1 and as a F2, and if you discover it later, maybe you can take an F3 like I did then, and work more into the specialty. Say you're interested in cardiology, you will go then into take a trust job in cardiology, learn more about cardiology, build up your skills, and then you can write it in your like portfolio. This is what I did. Then comes interviews. Every specialty has different interviews. So surgery has their own interview stations, and like and in everyone there's always a portfolio station. And in surgery there was like there's a leadership station and a clinical station. I think in medicine is also a portfolio station, ethical station, a communication, professionalism station. In GP there are more like you do the exam, and then you do kind of clinical stations, where you have like 3 different clinical stations that bring in a patient, they bring in a health professional, and they bring a family of the patient, so next of the kin of the patient, and then there are scenarios. So whichever specialty you choose, just know, is it something which fits my lifestyle, my character, my passion? Do I really want to be a surgeon? Do I really want to be a gastro consultant? Do I want to be a respiratory physician? So whatever you like and enjoy during med school, maybe during your F1, F2, will then lead you to what you want to do in the future.
Yeah, there's a question here that says, when do you recommend we choose the speciality we want to specialize in?
So there's no real like timing, okay, and that point, if you don't choose it, that's it, it's over, game over. No, it's not. But you know, you will always have a feeling, like during lectures, say, you learn about cardiology and you say, oh, that's interesting, that I can picture myself doing. Then you do maybe your placement into surgery and say, okay, I enjoy that. I enjoy looking at the all these abdominal surgeries. I like the surgical environment. I like theaters. I like the scrubs. There are a lot of things which make you choose. Or you do a small GP GP placement, and you say, okay, I love this communication with the patients, the contact with them, them coming back to me, like having a rapport with them, knowing them. I like being in a community setting, but just remember, whichever specialty you choose, there are their challenges as well during that time, and there will be also the benefits. So if it is maybe as a in medicine, yes, you are protected in the hospital setting. You need an x-ray, you get an x-ray. You want blood, ECG, you get this all done in the hospital setting. But in GP, it might be more challenging. However, you will learn how to manage chronic conditions with what is given to you. You will know a lot of more diagnosis, a lot of more conditions than other places. You will learn much more, or initiate more treatment, and also have the responsibility to take care of the grandma, the mother, the child. You will know a whole family structure. You will advise, change people's lives during the time you are a GP. In surgery, you will be doing more things that involves you to not just diagnose a patient, but also take them to theater, sort out the problem there and then manage the aftercare. So whichever specialty you choose at the end of the day, if it's during med school or later, there is no set timing where I tell you, and after your first year, you should know where to go. But just think about it. Just whatever you do during your placement, see, can I picture myself there? Ask your friends, do you think I would be a good anesthetist? They say, yes. Oh my God, you're so good in physiology and you love sitting there watching people. That's so, or am I a surgeon? You're like, yes, you love creating things. You're good in suturing. Am I a GP? Yes, your communications are great. I saw you in the GP placement. The patient loved you. So whichever specialty you think is for you, just if you know for sure. I mean, I knew for sure, and I worked towards it, and then changed my mind at the end. So there's no right or wrong answer. Just see what you really want to do in life, because at the end of the day, in medicine is your life. Like we see ourselves, yes, I am a wife, I'm a mother, whatever you guys are. I am a sister, but most of the time we see ourselves, I'm a doctor, and you have responsibilities 24/7. If you do anything wrong in public, you as a doctor, you need to be professional all the time. You cannot go around doing something else in public and then being also a doctor. So so the professionalism, or you are in a plane or on a train and they need a doctor, you have a responsibility to act upon it, because you might not be the most experienced doctor, but at this time you're more experienced than the other people who are there.
Yeah. Another, by the way, that was a very interesting answer that I'm keeping in mind for myself.
Me too.
Because me and Mona, we're both going into our third year. I don't know about Mona, but I used to think I knew what I wanted, and now I'm like clueless. I'm like, I don't even know like what.
I've always been clueless. I literally never know.
But yeah.
It will come. It all will come by time.
So sorry guys, we're going a little bit over time, but we're just answering the rest of the questions. There's two questions here that are very similar.
Yeah.
And one is, how do you balance career with family life? And then the second is it hard to have children / bring up a family and be a doctor?
Okay, so generally, as I said, as a doctor, it is your life. It is true. Like, you have your responsibilities. You are your life involves your rota. So, say I have night shifts, my partner doesn't, or I'm on call, or I'm working in a clinic all the time, and most of the time, sometimes we overrun. We can't always stick to commitments. So people around us should know that, like, I do have the responsibility. Yes, it is not everything, but it is quite a big part of my life, being a doctor. So what we need to understand is this is where organization, time management, and teamwork comes into play. Because say you have your child is unwell and you are still a doctor, you can always talk to your colleague and say, you know what, my daughter is today very unwell. I don't feel happy to leave her on her own. Can you cover my shift today? Or can you cover my clinic today? And then you will find some people who can. And if not, then you need to communicate to your senior this, to your consultant. Maybe they will find another person to cover your shift. So it is challenging to know, but I think through experience you will find out what you want. So if it is family life, you're looking for a good balance, maybe you are looking into a GP or a community job rather than being a surgeon, because you know that there might be more challenges to be a surgeon and having children than being a GP and having a children. However, it's not impossible. I've seen a lot of great female surgeons out there who have children and who manage to be great in what they're doing. So you need to have supportive partners, you need to have supportive family, and there's always also, you need to know yourself. Is it worth it for me to go to this conference, or do I really have to do this extra clinic, or can I take it off and spend with my family? Then you have your annual leave. Always, in every rotation you do, take it early, because it's going to clash with a lot of people. So if you have special days where you say, okay, this week I have to take time off because I want to travel, always also plan ahead and say, you know what, I have, say, a 4-month or 6-month rotation. So I'm going to start A&E in August for 6 months. Already now, I've booked myself holidays for end of September, in November, couple of days in December, in January, because I know that January, I'm human. I can't work most of the time 24/7 and also like manage family life. So I need to plan ahead and see in my annual leave I can enjoy myself and also
I think it transitions very well to the next question of, can you be a part-time doctor?
Yes. There are a lot of people who are part-time. Even in training, when you are part-time, you're going to be matched with another doctor who does part-time. So then they kind of cover your shift. So we had some registrars who were part-time in, I think it was elderly medicine, and one would cover like Monday to Wednesday, the other Thursday, Friday, and then even the clinics was like shared. So if you indicate early on you need part-time because of family life, because of health, because of whatever your reason will be, they will accommodate you. If you then maybe during your placements, during your rotation, say this is too much for me, mentally is too much, or because I can't see my family, I don't really interact with people because I'm so focusing on work, then you speak to your supervisor. In every rotation and every job you do, you have a clinical supervisor and an education supervisor who, when you go to them, they will support you because they are trained to support their trainees. So then they will then ask you and show you the process into how to get into part-time training.
Thank you. That's brilliant. I didn't even really think about that until just now, about part-time practice.
There are so many options as a doctor, what you can do. As I told you as well, I like surgery, but I can't be a complete surgeon. So I do basic minor surgeries in GP. So, or I can take days and be a hospital doctor for a couple of days, cover couple of surgical clinics. There's always lack of options to do things.
It's quite flexible. Yeah, that's really true. All right, there's another question here that is, sorry, 1 second. I'm just bringing up the Q&A.
I think it says it here. How do you think the NHS has been affected by the coronavirus? I think from a doctor's perspective, because Mona and I spoke about it as a medical student's perspective, and then we also spoke about how the virus affects your application process.
Mm-hmm.
But from a doctor's perspective, how do you think the coronavirus has affected the NHS?
I think it was quite a shock to the NHS. I didn't feel we were very prepared for it. but that's the challenges we're facing as doctors. So sometimes we are thrown into the deep end and we will come out great. So what happened to us is, the thing is, everything shifted from the hospital. Is shifted into, we need more juniors into medicine. So I was doing, I was covering a surgical job during the COVID time. Well, the peak of the COVID. Let's see what's going. It's still there. So they asked all the juniors, all the F1s, F2s, SHOs to all move into like the SHOs into ITU, because they needed more ITU trainees to help with the patient who are very unwell, and the F1s to move into COVID wards, because surgically we couldn't operate acutely, which was a very, very challenging time, because I mean, you always have appendicitis, you will always have bowel obstructions, you will have pancreatitis, you will have cholecystitis. There are a lot of acute surgical conditions where we had to rethink our options. We had to trial only IV antibiotics and only operate on people who really, really, really needed to do them. And there comes the being a doctor, by weighing out risk and benefits, which you do in every time to see, is this really something which will save my patient, or will I cause them more harm? So a lot of things shifted. So people had to go to ITU, where they had to do a job they've never done before. Some juniors F1s had to go back to medicine, so they had to cover the same specialties again. And then they kept rotating them as well. So having people who cover COVID wards for a while, then go for the people who went COVID. But at the end, everyone became COVID in the hospital, so this didn't really matter. You needed to get more skills. You needed to learn about PPEs, how to wear them, how to gown up, how to react during crash calls, where, okay, you have a crash call. No, you have to you wear your PPE quickly and then go to the crash call. So a lot of things changed, which were very different and very, very challenging. You had to make decisions on the door. You had to say, okay, so this patient, would he benefit coming to the hospital, or should we leave him and make the difficult decision for him to stay home, be safe at home, and maybe this is the best for him, rather than die alone in a hospital setting where nothing can really be done for them. They wouldn't be candidates for ITU, they wouldn't survive it. Any oxygen wouldn't help them as well. So there were a lot of challenges. We faced so many deaths. I mean, as a doctor, you see so much happening anyway. You will lose some of your patients, some of them which you've treated for a long period of time, and suddenly they go very unwell. Some of them you just met on your on call, and you try so hard to save them. So more challenges. We've seen young people dying from COVID. We've seen old people suffering from it. We've seen miracles. We've seen people who honestly we thought, oh my God, if they get COVID, I hope they will survive it, and they survived it with their many comorbidities. So it was, and it still is, a challenging time for doctors, nurses, and all other health professionals. But we have worked very hard. We have learned from some challenges, some mistakes, and worked on how to be safe for the patient and for ourselves as well.
Thank you, Dr. Raji. I think just to end with the last question, because we've gone quite over time, but the last question I hope is a good one.
Okay, it's breaking off, sorry. Hello?
Can you travel while being a doctor? Hello?
Yes. So can you travel when you are a doctor, you said?
Yeah.
Okay, so there's a traveling as, or I'll do it during my annual leave, and there are traveling as I do it, maybe take an F3 and travel. There are types of travel where you join other societies where and go and help, say there are more, like now with the refugee crisis we had, then with Ebola. So there are always organizations which go out there, need some young doctors. However, you need to know that as a FY1, you are pre-registered. So you are not registered to prescribe medication outside your hospital or work outside your FY1 training. And even as a FY2, I don't think that they would take you as a SHO. However, later on, you can always apply, travel to areas where you are needed to work, and then gain a lot of experience there. Other things, if you mean like as an enjoyable travel, like traveling just for your sake, yes, but you need to be smart about it. So your annual leave, as I said, book it early so you can have like a week off or 2 weeks off, by managing like, oh, if I go out of a night, I have here 2 days, then I start another night shift 2 weeks ago, maybe I can get these day shifts all off, because it's quite difficult, because there are a lot of doctors and you can't sometimes take your annual leave if another doctor has taken it. So, and then if you have a good block, you can go travel, you can enjoy yourself. And I think we all need it as well. We need to look forward for something. We need to change our mindset, because as I know, we are medic and it is quite a big part of our life. We need to take care of our mental well-being, especially young doctors. I've witnessed it in many cases where we had young doctors have faced a lot of challenges, because it is an environment where stresses are always high, adrenaline is always high. Also, sometimes you might work with people who are challenging, who there might be character clash. So there are a lot of challenges you face during the time, so you need a break. That's why when I said during medical school, you need to learn how to deal with stress as well. If it is like you meet with friends and let everything out? Is it you need counseling? You need support from your GP maybe? You need your family. You need to travel. You need sports. So you need from early on to know how to deal with your stresses, anxieties, and so on. Because at the end of the the end of the day, you want to be a doctor for a long period of time. So you need to be healthy. So taking breaks during your shifts, even telling people, okay, you know, tell your colleagues, you know what, I'm a bit tired today. I don't feel very well today. I'm a bit nervous. Is it okay if I take 10 minutes for myself? And we all, honestly, all doctors go through the same thing. There will be great days and there will be very days where you either want to cry because you are just overwhelmed, and or you want to cry because you lost a patient of yours which you thought you will make it. So where then these help periods come is from your seniors, from your colleagues, from your family. So, and everyone has been in the same stage, so they will be happy to help you. I had sometimes nurses come up to me and say, you know what, do you want tea? Even during the night shift where it was so busy, said, okay, honestly, stop that right now, just have your tea. Okay. And then I sat there on the ward, having tea quickly before seeing another patient, because we are so bad in taking breaks. Even like our bladders, they know how to expand during on calls, that it's just a miracle. But then later on you will have consequences. So take care of yourself, support each other. You're all young doctors, that you will have good days, bad days. So you're all together for doing great job. And as I said, you deserve it and you worked hard for it.
Thank you so much, Dr. Raji. That was
Thank you.
advice, honestly.
You're welcome.
And I think because we've gone over time by quite a bit, I just want to say a big thank you to Dr. Raji for being on our webinar today. It's been So
was a pleasure.
informative, super educational,
We
and
couldn't have asked for a better speaker. Thank you so much.
Thank you.
we hope everybody has been able to gain some sort of insight to what a day in the life of a doctor is really like. And if you want any more information on any of our other webinars, you can go on our website, intomedicine.co.uk, or follow us on Instagram, into.medicine. And we hope you guys all have a lovely evening.
Thank you, everyone, and good luck with your applications, with your medical school, with your starting as F1.
Thank you.
Thank you. Bye bye.
Okay. Thanks so much. Goodbye.